slide. Right, and this brings us on to pathways. This is something I started doing with my junior doctors, because when I had this junior doctor this time round, and I'll work with her, you know, I'm beginning to use the math for medicine now, but previously I was making pathways for them for each new patient that they had. Yeah, so if they had a patient who was a query depression, because to me and to the rest of us it's very clear now because we have set pathways in our minds. But when this, we don't know what other people's pathways are, and that's why I was sometimes really surprised by other people's management, because you're like, look, this is a really logical way of going, how come you don't get that? And they're like, we just never thought about it like that. And actually my own way might be flawed as well. You know, if somebody comes up with a better pathway than the one I have in my brain, then I'm most willing to listen to that. And I think that's the key. So, can we work without pathways? I'm just opening up the question to... So we all have pathways in our minds, don't we? And the question is whether these need to be written down, whether we need to share them. These are the key things. What are the risks? What are the risks of pathways?
Take off the initiative.
Yeah, and in some ways, you know, the pathways, the whole pathways thing, it scares me because, you know, psychiatry is about, as I said, I did the talk on the art of listening, and I really believe listening is a very, very important skill to have. And it's an art, and a pathway is going to detract from that. It's about getting the patient's story and really getting them to feel as if you've listened to them. And if we're not able to do that, a pathway is going to take us away from that, and that's what worries me as well. Benefits of pathways?
It gives us structure to work.
Yeah, it gives us a structure to our work, but for me the single most important thing is patients have a basic minimum level of care. I've had patients who have come to me and said, in 20 years I haven't had this experience, or I haven't been given any choice about my medication, nobody's ever explained my diagnosis, nobody's ever talked about this. And 20 years, it's a long time. I mean, these people, you know, they're the illest people in our society. Okay, if you have a physical illness, you know, you can sort of cope with it and it's difficult. But with a mental illness, it's so difficult. And that's why my view now is that we do need a basic minimum that we need to agree with. So, okay, we're going to just design a quick pathway just to show you what I mean by the pathways we think about. Can I have a volunteer, because I can't get up and write, if that's... James, I think you're looking.
I'll do the button and right.
You've got to do the button and right. Okay, so we've got a patient. Now just imagine yourselves not knowing any psychiatry whatsoever and being like my junior doctor. Yeah? So I'm sitting with my junior doctor, and there's a patient who's there's a GP referral, somebody with depression who's on citalopram. And I'm telling my junior doctor, who's got no experience with psychiatry, on the kind of things, the pathway she's going to have in her mind. So what's the first thing I'm going to ask her to do?
We want to confirm the diagnosis.
Okay, good. So confirm the diagnosis. So about maybe take a history and do a mental state examination. So if we can put that right at the front. And with the history and mental state examination, I want there to be the ICD-10 criteria there. So I want her to go through the 10 symptoms and say to me whether it's mild, moderate, or severe. Yeah, in my mind, that's the sort of simplest thing. Okay, so history, mental state, diagnosis. What would come after that?
The risk.
Risk, absolutely, yeah. Does risk come before diagnosis?
Often it does.
Sorry?
Often it does.
It does, doesn't it? So, I mean, that's a question whether we put the risk box before the diagnosis or do we put the diagnosis box afterwards. What's the process that we go through in our own minds when we've got a patient in front of us? Okay, so I might go there, I'm not exactly sure. But then, depending on so with the risk, there's going to be two separate things. If the risk is high, so we can branch into two bits with the risk, of high risk or low risk. Or we could go into low, medium and high. If it's low, we might just be willing to send them home with the medication that we've decided. If it's medium, then we might think of the crisis resolution and home treatment team. And if it's high, we might consider admission. Yeah? And then depending on mild, moderate to severe, James is struggling a bit there. And then there's a risk arm on one side and there's a diagnosis arm on the other side. And again, with the diagnosis, it's mild, moderate, severe. With mild, it might be counselling or CBT. And then with moderate or severe, it might be the antidepressant, the dose might need increasing, or we might need an increased dose. And these are the pathways that I have in my mind. Now, you might have different ones, and we have different ones for each illness. But the key thing to remember is that not everybody has these. Everybody has different ones. And that's why patients get a very different experience. And often patients get a very poor experience because somebody hasn't worked it out in their mind properly what a pathway should look like. Does that make sense? So that's a sort of pathway. Sorry.
I'm just thinking a little bit confused because coming from a psychology background, maybe I would be doing that automatically anyway. And that, are you just coming in to actually doing that in the medical knowledge?
Sorry, we do all these things automatically. Yeah, I completely agree with you all these things. But you as a psychologist, another psychologist might be doing something very different to you. Which might mean, I have some patients who are referred to psychology and for CBT, and when they go to CBT, you think they've got a fairly equal chance of having a good experience from CBT. Some will come back and say, I was absolutely useless and I didn't benefit at all when I left after the 7th session. Another will come back and say, I had a wonderful experience and I feel much better. Is it because of the experience they've had, because you've got a different pathway in your mind?
It may not
than
have to do
somebody
with
else?
pathway at all. It may be to do more about the relationship that those two people have actually been able to form and maintain with each other.
Absolutely, I agree, yeah. But what I'm saying is that the patient should have a basic minimum that they know happens. I mean, with psychology, if you go down a CBT arm, for example, so for you, there might be no pathways required at all because you have it in your mind and you have a certain treatment. But to get to you, you know, like when should somebody refer for CBT, when should somebody refer for psychodynamic psychotherapy, or for CAT, or for different psychotherapies, and people need that guidance. So even for me, I don't sit there using any of these pathways. I don't use map of medicine when I'm in clinic or anything, but it's for the other people who, you know, some of the junior doctors who are new to, I'll talk about the people it's useful for, but the reason I'm talking about pathways is because I think there needs to be a basic
Are we talking, with the pathways, we're talking about sort of an education of us like your junior doctors?
junior doctors, nursing staff, you know, people who maybe don't know what depression is and who need to see it there, you know, on the map or on a piece of paper or something.
I suppose one of my concerns is sort of working with a lot of particularly young men is actually we're very quick to give that diagnosis by pathway. You know, you've got depression and it's either this, this and this.
That's true, but you see,
And
when
that has huge ramifications on their lives.
yeah, but when
Actually, this might be a discussion worth having at the end when all of us sit together.
yeah, I'd like to. I'll just park that. Could you just write that question down? Because I would like to answer that later.
I think just before we as we move on, in what what you're calling pathway, because the bit which is lacking is the psychological formulation in a way, and that's what I would put rather than to say diagnosis.
Right. Okay. Yeah.
Because you can't think that. I mean, I work in the early intervention team. We don't make diagnoses until assessing people sometimes for a year, for 2 years. It's not like an instant thing which you would like.
Yeah, so we can put that in the pathway. So that's what I'm getting at, that you have a different sort of pathway, and psychology might have different. So we all have different ones. But it might be that in early intervention, that might be the routine practice of waiting for a year before giving a diagnosis. Whereas in adult psychiatry, it might not be. When you have one new patient appointment to decide what's wrong with somebody, we often are sort of pressured to make a diagnosis. Okay, should we move on to the next?